How many of you have seen this movie? It's wonderful, isn't it? It's got to win some Academy Awards. And this is one of my favorite statements from this movie that's applicable to lots of things and lots of things we're talking about today. Everything will be okay in the end. If it's not okay now, it's not yet the end. And we certainly know we're not where we need to be yet with these bridges and collaboration that needs to be built. We're working on that. It's got to be exciting for you to be here today, to be on the forefront of making that happen with these bridges. And one thing that we haven't said yet, but we do have a book coming out for the public. John Wiley and Sons contracted with us a year and a half ago. And the public's going to start demanding this type of care. So it will be a national bestseller. So you'll be in position to take advantage of that demand from the public. The other reason I put that statement up there is because this case goes back 5 years. And we are honored to have the patient in our midst. And I think he plans on saying a few words at the end of this case, but this was 5 years ago. He's 44 and basically a very healthy man, but he has a bad family history. And they have 2 sons that are young, and his wife insists that he come in to get checked because of that family history. He's not on any medicines. His habits are fine. He has some migraine headaches. He's happily married and has a successful company. That all looks good. He just came in to be nice, make sure his wife stays happy. So we nicknamed this guy Superman because if you look at the physical exam there, I think you would agree, this is a Superman. He's in great shape. He's got a good weight, blood pressure. His waist is excellent. His exam was perfectly normal. It was a picture of health. So we get the standard labs, and his cholesterol is good. His fasting blood sugar is great at 83. Kidneys are working well. The liver's fine. Thyroid, white cells. We calculate the standard of care risk scores, tells you, look, this guy's not going to have any heart attack soon. He's low risk. So the standard of care would, of course, tell him at the end of that evaluation, you were smart to come in, keep your wife happy, but look, she's wrong. You're fine. Just keep doing what you're doing and forget it. You don't need to come back. Of course, we go further than that, and we do believe inflammation is the cause of disease. If you look at his inflammatory tests, he's got some bad news there. The CRP's up, the microalbumin, so we know the tennis court's hot. And the worst news, the myeloperoxidase, which is the joker again, when that's elevated, it should be under 480, all bets are off. So it doesn't matter what anything else is up here, we believe he's in trouble. So our method would state and educate the patient that this is silent disease. Frequently we need to look for disease. We couldn't find any in the record. We would recommend doing a test to find out. So he did the carotid test. And this is bottom line what we found. Soft plaque means there's no calcium. That's the most dangerous stuff. That's a nice young limber cat that could jump out. And when you got one that's 3 millimeters, that's not a cat, that's a tiger. You only have about 6 millimeters to work with. He's got a 3 millimeter tiger in that gutter. So Superman's in big trouble. Looks like he may beat his father to the stroke, doesn't it? Have a stroke even at a younger age than his father. So our advice is, look, your wife, of course, was right. It's lucky you came in. You've got disease, you're high risk. You know, we need to get after this. So I put him on a statin, antiplatelet therapy in case the tiger jumped out, gave him some omega-3. And this is after a year of treatment. If you believe cholesterol is the answer, which actually most of our medical colleagues still believe it's all about cholesterol. A lot of cardiologists still believe that. You'd look at his results a year later, You'd say, Superman, you're great. Just pat him on the back. You're good to go. Let's just keep doing what we're doing. If you believe what we're talking about and you look at inflammation, you start shaking in your boots. Like, oh my gosh, you're worse off than you were when you first came in. There's more fire there now than there was before. So who's correct? The standard of care, which says, look, you got his lipids at goal, that's all you need to do. He's good to go. Or is the new theory about inflammation correct? How could you find out? Obviously, you could look at the disease again, couldn't you? What's going on with the tiger? Is he shrinking? Is he calcifying? Is he looking good? So we repeated the carotid test, and I'll make it easy for you. This is what happened after a year of my therapy. The thickness of the carotid artery increased. He went from a 62-year-old, he was only 44, up to a 70-year-old. After a year of my therapy, he's 37% more likely to have a stroke than when I first saw him. And that's not obviously good news. So I'd always try and throw a positive spin on things. So I'm looking at this information. Oh my gosh, I've been treating him for a year. He's a higher risk now than when he first saw me. How can I make this positive? I said, oh, I know. Thank goodness I don't treat myself. I have Amy treat me. So he's still on fire. We have to put it out. I've got to give him the results. I want his wife involved in that result, since she's the one that got him to come in the first place. And we explained, look, if we want to keep your body warm, we have to keep the arteries cold. If your artery's hot, your body's going to get real cold. Okay, so he got back on the niacin. Things cooled off. We repeated the carotid test. And again, I'll make it easy for you. Now that the artery's cold, look at what's happening. The tiger's starting to shrink and get calcium in it. This looks good. So this is after the second year. At least we're making some progress. But you do have to maintain vigilance over the fire, the inflammation. So this is the first year bad news, second year good news, third year good news. Now we're into the fourth year, and I'm looking down here and say, whoa, that's not good, and that's not good. So it looks like the fire's rekindling. So at that time, somebody very important had entered into our method, and that was Dr. Neighbors. So we were aware by this time of the very sophisticated testing available to check for periodontal disease. So we got those tests on Superman. This is not good news, and this is not good news. So we said, okay, get some treatment. I want to recheck the fire again in about a month or 6 weeks. So he comes back in about 6 weeks, and the cholesterol is actually worse. And again, what can cause that? Periodontal disease, and the fire's worse than it was. So I said, I don't understand this. And he said, well, I haven't started the treatment yet. I said, well, you need to start the treatment. So he went on what he calls his daily mouth car wash. The report came back okay after he was on that. The disease cooled off here. I'm going to jump all the way to very recently. I saw him not long ago. Everything still looks good. And this is what the very latest carotid test, and this was done just a little over a month ago. Look at the tiger now. You can call it a cat. And he's, what? Explain the E means, calcified, echogenic, like the sound waves won't go through. So he went from a soft tiger to a calcified little wimpy cat that isn't going to jump out of there, okay? But it's inflammation. This is what you want. And this is why he's doing all this for his two sons, Charlie and Jack, who are great athletes. I think they'll be pro athletes. But we're not done. You do have to maintain vigilance over the fire. Abraham Lincoln said, with vigilance, go forward and give us victories. You all need to remember that. We all need to remember that. So you have to maintain vigilance over the fire and over his periodontal disease. So this was done very recently. Got a little issue there, but the real high-risk ones are wiped out. And his probe chart, he's got a couple of little areas of bleeding, but overall it looks better than it did before. But we're going to maintain vigilance over this condition. We're not going to say, oh, well, you're fine. You got these calcified cats in there now, so we don't need to worry about your periodontal disease anymore or the fire. Are you kidding me? We have to continue to be concerned about that and monitor it. And Amy and I, some of you know this, we do guarantee our work. Patients that see us personally, if they were to suffer an atherothrombotic heart attack or stroke, the fees they paid to us, we would give it back to them. And our whole guarantee rests with the fire. We have to put the fire out, we have to extinguish it, and we have to keep it out. So if you do that, you're not going to have an event. And I'm going to tell them real quickly, I got some great news today I'm excited about. I have to tell you, just it won't take more than a minute. This guy's 89 now. His goal is to live to be 113. He flew to see me 5 years ago after he was told by some of the best doctors in Houston, Texas, if he wanted to stay around, he needed coronary bypass. He'd already totally plugged off one of the arteries, but he didn't want bypass, and he didn't want any stents. So he came to see me. We started giving him medical therapy. We updated the angiogram today. That's why I left the room when Tom was talking, because they called and they said, we want to give you the result. So after 5 years of medical therapy, this gentleman, his ejection fraction, which is how well the heart's pumping, improved over the last 5 years. It went from 55% to 60%, which probably some of us in the room don't have an ejection fraction of 60%. That's actually very, very good. And they saw that he's got tons of new vessels supplying his heart with blood now, angiogenesis, and he's never had a heart attack, no heart attacks. So what did the cardiologist recommend? Continue your medical therapy. Medical therapy works, but for the whole 5 years, his artery's been cold as ice. So it's about putting out the fire. But we do have Superman in the audience. I don't know if he wants to say a few words or... No? Okay. They won't. We're going to keep those arteries cold. Yeah. Yeah, Kelly, do you want to say something? Sure. Kelly, we appreciate you sharing that.
Absolutely.
And
Yeah, absolutely.
thank you very much.
Can I make a comment on that?
Yeah, and she's the one that I'm collaborating with now to make sure we keep Superman around, keep those arteries cold, but thanks.
Yeah, may I make a comment? Kelly, I really appreciate that, and also Wesley, thank you for your comments. But what Kelly is saying is reflective of the events associated with periodontal disease. The very second slide, or third slide that I showed. And what we have to realize is what physicians are already realizing, and that is the event is the last thing that happens. The first thing that happens with periodontal disease is what? Bacteria. So subclinical infections do exist, and that's a perfect example of that. We would not have called him periodontal disease, but subclinical disease without significant clinical signs of breakdown is what we need to be aware of. It's common in their world. It should be common in our world that we recognize subclinical disease. Thank you.
Okay, so I think we just open it up for anybody have a question or comment for anybody up here.
Yeah, so dentists can order the labs. Who asked the question? Okay, dentists can order those labs. If you want to do them through Cleveland, you can check the box and get all of them right there. You don't need ICD-9 codes. It's really a cash pay model. So you can order them right there. Or if you want to get them at other labs, you can do that. This just was kind of a nice package opportunity. Cleveland Heart Lab is the developer of myeloperoxidase. They also do a lot of other labs, so it was kind of a nice fit to just be able to do them there. They're non-fasting. That's why we included A1C. You don't have to be fasting to include A1C, so they can be done at any time, and the patient would have to just bring the requisition form into any lab and they could get that done.
Well,
yes and no. I mean, actually, they need to, you need to actually talk to Cleveland and make sure that the lab that you're taking them to can do Cleveland labs. It's not, they'll mail the packet to the patient. They may have to bring it into the office, but anyway, it can be done is the point.
Yeah, you do want to check it out with Cleveland first and make sure whatever lab they're going to has the Cleveland Heart Lab kit with the right tubes in it, and that the lab is willing to ship the blood off to the Cleveland Heart Lab.
Yeah, where's the mic?
And they can help facilitate that. The safest way to do it would be to contact Cleveland Heart Lab first if you're going to do the tests through them.
Mm-hmm.
Yeah, that's what I did when I went home and I wanted to do the tests. I just contacted Cleveland. I said, who do you have in my area that uses your tests? And then they gave me the name of a couple people. So Cleveland will direct you because there's one proprietary test to Cleveland. The other ones you might be able to get someplace else.
Yeah, perfect.
Right. Yeah, good question. Okay. Yeah, Chris?
Dentists can order these tests, and one of the areas where I felt some resistance, and I've shared this with you as well, is that sometimes the medical professionals treating my patients say, hey, why do we need this test? We're already doing everything we can for them to prevent a risk. We've got them on statins and whatever. And I kind of go, I don't know.
Ask them if they've taken the Bale-Donine method 2-day course.
Well, one thought, Chris, on that is to say, if they already have that patient on treatment, then if the treatment's working, there should be no inflammation, period. So if they have that patient on treatment and some of those labs are off, clearly the treatment isn't really probably treating the root cause. And so it's an opportunity to have that discussion because their treatment should be working.
So let's see if your treatment is working.
That's right.
Yeah,
Let's check
exactly.
you out. Here's your report card. Is it working or not?
Yeah, they need to be aware that numerous pathologies can drive arterial inflammation. Periodontal disease certainly is one of them, and one of the more frequent ones. But we have data now,
Sure.
anxiety. They've measured inflammatory levels in people who are anxious. They're high. When you're sleep deprived, you have increased oxidized fatty acids. Oxidized fatty acids turn on the toll receptors, and the nuclear factor kappa beta goes in. So they need to know it's a lot more than cholesterol. Because usually when they're saying that, oh, it's like Superman. Look, his cholesterol's fine. I'm doing everything I can for him. He's okay. Don't worry about it.
Oftentimes, I'm just looking for their support to support
Sure.
the periodontal aspect of it.
Yeah.
That's all it's
Yeah.
You're who, you do what?
Yeah, right.
But we're getting there, and this, the letter you have
Yeah.
is really great. So
Oh, good,
thank you for
good, yes.
One of the objections some of my patients have to the antibiotics is that the concerns can create resistant forms. Have you seen any evidence of that?
Yeah. Yeah, the question is, one of the patient's concerns, I think that's what you said, is that, yeah, the use of systemic antibiotics, potential resistant strains of bacteria. I would say that's a rather educated patient. Most patients don't ask that question, but even if, let's say, someone else asks that question or the patient asks that question, we do know that periodontal pathogens do have some resistance to some of the antibiotics. There's no doubt about that. But we do also have good data that short-term duration of these antibiotics don't substantially increase the antibiotic sensitivity to specific bacteria. Here's one of the problems that we did in periodontal therapy that was so hurtful, and that is we were using tetracycline for so many years, which is broad-spectrum bacteriostatic, and that's where you have your real problems with bacterial-resistant or antibiotic-resistant microbes. The bactericidal narrow-spectrum antibiotics are working a lot better and less resistant. So just don't use the tetracyclines. But yes, there's risk. There's risk to any drug. There's risk to that. There's risk to stomach upset, diarrhea, all of those things. But you have to weigh the risk versus reward. If you believe that the medication is important, yeah, just say, be honest. Yes, that's a slight possibility, but it's short duration, targets the microbes, and if I were you, I would do that.
One follow-up to that.
Yeah.
At what point in the therapy, if your therapy is scaling or planning,
Yeah.
and then the antibiotic therapy, at what point in the therapy do you like to start the antibiotic?
Yeah, the antibiotics ideally, let's say on a healthy patient, we have no vascular inflammation, is after biofilm disruption. Why? Because the minimal inhibitory concentration of the antibiotic can get through the gingival clavicular fluid into the site where you have the majority of the biofilm in plaque tonic position, and your MIC can be very high very quickly. So immediately following your scaling and root planing, do that as quickly as possible. Put the patient on the antibiotic the day of your last visit, but make sure you revisit every tooth before you put, disrupt biofilm everywhere. Now, on a vascular inflamed patient, I would do it differently. Why? Because we don't want to injure their vasculature by introducing more bacteria into the bloodstream that may elevate their vascular inflammation. And the study from Annals of the Annals of Internal Medicine, 2010, clearly states that for up to 6 months, we increase vascular inflammation when we do invasive dental therapy. Extractions of teeth, periodontal therapy increase vascular inflammation. So we need to be aware of that. So what I would do for a patient that has a history of vascular disease, I'd put them on the antibiotic 1 day prior to my periodontal therapy. I'd finish periodontal therapy very quickly while they're on the antibiotic. That way I feel like I'm protecting their vascular system while I'm doing invasive treatment.
The antibiotics that were recommended by oral care?
Absolutely, yes.
So when you do it as a standard,
I'm sorry?
when you apply it as a standard to put patients on antibiotics prior to the surgery?
Would I do what now?
Would you do it as a standard for all your dental?
Yeah, would you put patients on the antibiotic as a standard? Yeah, prior to the service. I think that's where we're going with that. In other words, because of the annals of internal medicine study, now that we increase vascular inflammation, he's asking the question, would you now change your regimen, put the patient on the antibiotic prior to therapy? I would give some serious considerations to doing that, absolutely. Because now we're not just treating periodontal disease, we're trying to influence systemic inflammation. So the literature in periodontal therapy says do it after biofilm removal. Now that we are learning the risk associated with invasive dental procedures, I think you make that decision on your own. I don't have the literature to support that, but I think you all have enough information to suggest that as a possibility. Absolutely. You make that decision.
Yeah, we're out of time.
Oh, we're out of time now.
So
Okay.
Let's,
Time to introduce.
So let's say that you need 4 visits,
4 visits.
start with 4, and stop it, or keep on?
Yeah, so if you have to do 4 visits, try to do it during that week that they're on the antibiotic, if you possibly can. But if you have to start and stop, make sure you get through the 8 days and try not to go more than 2. I try to keep them on just 8 days, but change your schedule so that you can get them through treatment while they're on the antibiotic. That way you're not giving them more antibiotics than you need to.